Good day, everyone. My name is Novelin S. Solaris, and my report is all about neuropsychological assessment. Now, neurology is the branch of medicine that focuses on nervous system and its disorders. Neuropsychology, on the other hand, is the branch of psychology that focuses on the relationship between brain functioning and the behavior. Neuropsychologists study the nervous system as it relates to behavior by using various tools, including neuropsychological assessment. Now, neuropsychological assessment is the evaluation of brain and nervous system functioning as it relates to behavior. Now, the subspecialty areas with neuropsychology include pediatric neuropsychology, geriatric neuropsychology, forensic neuropsychology, and school neuropsychology. Now, the behavioral neuropsychology is a subspecialty within the medical specialty of neurology that also focuses on brain behavior relationships, with more biochemical and less behavioral emphasis. Now, in our topic, we will begin with a brief introduction to brain behavior relationships because this will lay a foundation for understanding how test taking, as well as other behavior, can be evaluated to form hypotheses about levels of brain intactness and functioning. Now, the nervous system, as you could see on the screen, the nervous system is composed of various kinds of neurons or nerve cells, and it can be divided into the central nervous system that consisting the brain and the spinal cord, and the peripheral nervous system consisting of the neurons that convey messages to and from the rest of the body. Now, the large, rounded portion of the brain is called the cerebrum and can be divided into two sections or hemispheres, the right hemisphere and the left hemisphere. Now, contralateral control is that each of the two cerebral hemispheres receives sensory information from the opposite side of the body and also controls motor responses on the opposite side of the body. It is due to the brain's contralateral control of the body that an injury to the right side of the brain may result in sensory or motor defects on the left side of the body. Now, the meeting ground of the hemisphere or the two hemispheres is the corpus callosum. Although one hemisphere, most frequently the left one, is dominant, it is because the left hemisphere is most frequently dominant that most people are right-handed. Now, the dominant hemisphere leads in such activities as reading, writing, arithmetic, and speech, while the non-dominant hemisphere leads in tasks involving spatial and textual recognition, as well as art and music appreciation. Now, neurological damage may take the form of a lesion in the brain or any other site within the central or peripheral nervous system. Now, a lesion is a pathological alteration of tissue, such as that which could result from injury or infection. Now, neurological lesion may be physical or chemical in nature, and they are characterized as focal, which is relatively circumscribed at one site, or diffuse, scattered at various sites. Now, because different sites of the brain control various functions, focal and diffuse lesions at different sites will manifest themselves in varying behavioral deficits. Now, neurological assessment play a critical role in determining the extent of behavioral impairment that has occurred or can be expected to occur as the result of a neurological disorder or injury. Now, such diagnostic information is useful not only in designing remediation programs, but also in evaluating the consequences of drug treatments, physical training, and other therapy. Moreover, the terms brain damage, neurological damage, and organicity have unfortunately been used interchangeably in much of the psychological literature. Now, the term neurological damage is the most inclusive because it covers not only the damage of the brain, but also damage to the spinal cord and to all the components of the peripheral nervous system. While the use of the term organicity, it derives from the post-World War I research of the German neurologist Goldstein. His studies of brain-injured soldiers, the studies of brain-injured soldiers led Goldstein to the conclusion that the factors differentiating organically impaired from normal individuals included the loss of abstraction ability, deficits in reasoning ability, and inflexibility in problem solving tasks. Now, accordingly, Goldstein developed a psychological test that tapped these factors and were designed to help in the diagnosis of organic brain syndrome, or organicity for short. Now, neuropsychological examination. In neuropsychological examination, there are two signs, that is the hard sign and the soft sign. Now, hard sign is an indicator of definite neurological deficit. Abnormal reflex performance is an example of a hard sign, while soft sign is an indicator that is merely suggestive of neurological deficit. An example of a soft sign is a 15-point discrepancy between the verbal and performance scales on a Wechsler intelligence test. Now, signs, either hard and soft, and the symptoms may be present in case history data or may be present themselves during interviewing or testing or be evident in the test results. Now, the objective of the typical neuropsychological evaluation is to draw inferences about the structural and functional characteristics of a person's brain by evaluating an individual's behavior in defined stimulus response situations. Now, how the neuropsychological examination is conducted will vary as a function of number of factors, just such as the nature of the referral question, the capabilities of the patient, and the practical considerations, such as the time available to conduct the examination. The examination typically begins in the absence of the examinee, and those are case history data, um, including medical records, educational records, family reports, employer reports, and prior neuropsychological evaluation records would all be desirable to have in planning the examination. Now, common to all thorough neuropsychological examinations are a history taking, a mental status examination, and the administration of tests and procedures designed to reveal problems of neuropsychological functioning. Now, throughout the examination, the neuropsychologist's knowledge of neuroanatomy, neurochemistry, and neurophysiology are essential for optimal interpretation of the data. Now, in addition to guiding decisions concerning what to test for and how to test for it, such knowledge will also come into play with respect to the decisions concerning when to test. Now, for example, it would be atypical for a neuropsychologist to psychologically test a stroke victim immediately after the stroke has occurred, because some recovery of function could be expected to spontaneously occur in the weeks and months following the stroke. Now, testing the patient immediately after the stroke would therefore yield an erroneous picture of the extent of the damage. Furthermore, neuropsychologists must also have a knowledge of the possible effects of various prescription medications taken by their assistees, because such medication can actually cause certain neurobehavioral deficits. Now, many of the tools of neuropsychological assessment are tools with which most psychological assessors are quite familiar, and these are the test, the case study, and the interview. Some tools, such as imaging equipment, are modern marvels of technology. Now, I'm sorry, the tools of assessment used in neuropsychological examination vary as a function of several factors. They will vary, for example, with the purpose of the examination, the neurological intactness of the examinee, and the thoroughness of the examination. Now, in a sense, any routine administration of a psychological test or battery of tests in a clinical setting can also serve the purpose of neuropsychological screening. Now, beyond general screening purposes, an individual might be referred for an in depth neuropsychological evaluation because of the nature of a specific presenting problem, such as a complaint about loss of memory. Now, a neuropsychological examination might be ordered by a neurologist who seeks to find out more about cognitive and behavioral consequences of a suspected or known lesion. Now, note that although we refer what a neuropsychologist does, the clinicians doing such routine evaluation may not necessarily be a neuropsychologist. Still, the clinician may have received training in how to screen for signs and symptoms of neurological deficit. Now, history taking. Neuropsychologists pay careful attention of patients' histories as told to them by the patients themselves and as revealed in patients' records. Now, the typical neuropsychological examination begins with a careful history taking. Some specific areas of interest to the examiner include the following: the medical history of the patient, the medical history of the patient's immediate family and other relatives. A sample question here might be: have you or any of your relatives experienced dizziness, fainting, blackouts, or spasms? And the third one is the presence or absence of certain developmental milestones. It is particularly critical part of the history taking process when examining young children. And lastly, psychosocial history. It is including level of um, academic achievement, excuse me, estimated level of intelligence, an estimated level of adjustment at home and at work or school, and observations regarding personality. Now, a careful history or a careful history taking is critical to the accuracy of the assessment. A history taking interview can help shed light on questions of the organic or functional origin of an observed problem and whether the problem is progressive, that is likely to spread or worsen, or non progressive. Now, the data from a history taking interview may also lead the interviewer to suspect that the presenting problem has more to do with the malingering than with a neuropsychological deficit. Physical examination. Now, most neuropsychologists perform some kind of physical examination on patients, but the extent of this examination varies widely as a function of the expertise, competence, and confidence of the examiner. Now, non-invasive procedure, it is a procedures that do not involve any intrusion into the examinee's body, where neurologists perform as part of their neurological examination. Now, the clinician conducting a neuropsychological examination, on the other hand, may test for simple reflexes. Reflexes are involuntary motor response to stimuli. Now, many reflexes have survival value for infants, but then it disappears as the child grows older. Now, one such reflex is the mastication or chewing reflex. Stroking the tongue or lips will elicit chewing behavior in the normal infant. However, chewing elicited in the older child or adult indicates neurological deficit. Now, the physical examination aspect of the neuropsychological examination is designed to assess not only the functioning of the brain, but also aspects of the functioning of the nerves, muscles, and other organs and systems. Tests of executive function. Executive function is organizing, planning, cognitive flexibility, and inhibition of impulses and related activities associated with the frontal and the prefrontal lobes of the brain. One test used to measure executive function is the Tower of Hanoi. So, it is a puzzle that made its first appearance in Paris in 1883. It is set up by stacking the rings on one of the pegs, beginning with the largest diameter ring with no succeeding ring resting on the smaller one. So, as you have seen on the screen, and that is the example of the Tower of Hanoi. And we have another one, which is performance on mazes. It is another type of task used to measure executive function. Now, this type of task was originally introduced to yield a quantitative estimate of prudence, forethought, mental alertness, and power of sustained attention. And a test used to quickly screen for certain executive functions is the clock drawing test, which is or CDT. As its name implies, the task is this. In this test is for the patient to draw the face of a clock, usually with the hands of the clock indicating a particular time, such as 10 minutes after 11. Now, as used clinically, there are many variations of this test, not only in the time that the clock should indicate, but also in the setup of the task. Some clinicians begin the test with a pre-drawn circle, and in the scoring of the patient's production, there are more than a dozen of scoring systems. Now, observed abnormalities in the patient's drawing may be reflective of cognitive dysfunction resulting from dementia or other neurological or psychiatric conditions. Poor performance on the CDT has also been associated with visual memory deficits, mild cognitive impairment, and losses in the function that ostensibly result with aging. Moreover, there are four other types of tasks that may be used in neuropsychological assessment. First one is the trail making item. Now, the task is to connect the circles in a logical way. This type of task is thought to tap many abilities, including visual conceptual, visual motor, planning, and other cognitive abilities. The second one is field of search item. It is shown a sample on target stimulus, usually some sort of shape or design. The test taker must scan a field of various stimulus to match the sample. Now, this kind of item is usually timed. So, people with right hemisphere lesions may exhibit deficits in visual scanning ability, and the test of field of search ability can be of value in discovering such deficits. Confrontation naming, which is the third one. Confrontation naming, that is, naming each stimulus presented. Now, this seemingly simple task entails three component operations. First is a perceptual component, which is perceiving the visual features of the stimulus. Second is the semantic component, which is assessing the underlying conceptual representation or core meaning of whatever is pictured. And the third one is a lexical component, which is assessing and expressing the appropriate name. Now, difficulty with the naming task could therefore be due to deficits in any or all of these three components. Persons who are neurologically compromised as a result of Alzheimer's disease or other dementia typically experience difficulty with naming tasks. The fourth one is picture absurdity item. Now, the pictorial equivalent of a verbal absurdity item, the task here is to identify what is wrong or silly about the picture. It is similar to the picture absurdity items on the Stanford Binet intelligence test. As with the Wechsler type comprehension items, this type of item can provide insight into the test taker's social comprehension and reasoning abilities. Now, the tests for perceptual motor and perceptual motor function. The perceptual test is a general reference to any of many instruments and procedures used to evaluate varied aspects of sensory functioning, including aspects of insight, hearing, smell, touch, taste, and balance, while motor tests used to evaluate varied aspects of one's ability and mobility, including the ability to move limbs, eyes, or other parts of the body. Now, perceptual motor test is used to evaluate the integration or coordination of perceptual and motor abilities. For example, putting a jigsaw puzzle taps perceptual motor ability more specifically and high or hand eye coordination. Bender Visual Motor Gestalt Test. It is usually referred to simply as the Bender Gestalt or even just the Bender. Now, the test consisted of 9 cards, on each of which was printed one design. Believed, it is believed that these designs could be used to assess perceptual maturation and neurological impairment. Now, test takers were shown each of the cards in turn and instructed, copy it as best you can. Although there was no time limit, unusually long or short test times were considered um, to be of diagnostic significance. Average administration time for all 9 designs was about 5 minutes, a fact which all contributed to its wide appeal among test users. Tests for verbal functioning. Now, aphasia refers to a loss of ability to express oneself or to understand spoken or written language because of some neurological deficit. Now, written Indiana Aphasia Screening Test, or the AST, is available in both a child and an adult form, contains a variety of tasks such as naming common objects, following verbal instructions, and writing familiar words. Tests of memory. Now, memory is an active process that is presumed to entail both short term and long term components. Incoming information is processed in short term memory, where it is temporarily stored for as little as seconds or as long as a minute or two. Now, short-term memory has also been characterized by some researchers as virtually synonymous with working memory. Now, the more traditional view of short-term memory is as a passive buffer in which information is either transferred to long-term memory or dissipated, that is, forgotten. Now, procedural memory is a memory for things like driving a car, making entries on a keyboard, or riding a bicycle. While declarative memory, it refers to memory of factual material. Now, there are two components of declarative memory, that is, semantic and episodic memory. Semantic memory is, strictly speaking, memory for facts. Episodic memory is memory for facts in a particular context or situation. Now, an example for episodic or context dependent memory might be the recollection of a classmate's name while in class, but not at a chance meeting during a social event. Now, illicit memory, which is accessible only by indirect measures and not by conscious recollection. It has been referred to unconscious memory. Neuropsychological test batteries. Now, there are two types of test batteries. That is the fixed battery and the flexible battery. Fixed battery are designed to comprehensively sample the patient's neuropsychological functioning. The fixed battery is appealing to clinicians, especially clinicians who are relatively new to neuropsychological assessment because it tends to be less demanding in many ways. While flexible battery consists of an assortment of instruments handpicked for some purpose relevant to the unique aspects of the patient and the presenting problem. Now, the clinician who administers a flexible battery has not only the responsibility of selecting the test to be used, but also the burden of integrating all the findings from each of the individual's tests. No simple task because each test may have been normed on different populations. Another problem inherent in the use of a flexible battery is that the tests administered frequently overlap with respect to some of the functions tested, and the result is some waste in testing and scoring time. Halstead Written Neuropsychological Battery. This is the most widely used fixed neuropsychological battery. Another fixed neuropsychological battery is the Luria Nebraska Neuropsychological Battery, or the LNNB. The LNNB contains clinical scales designed to assess cognitive processes and functions. Analysis of scores on these scales may lead to judgment as to whether neuropsychological impairment exists, and if so, which area of the brain is affected. And the third one is the Neurosensory Center Comprehensive Examination of Aphasia, or the NCCEA. It is a battery of tests that focuses on communication deficit. The fourth one is the Severe Impairment Battery. It is designed for use with severely impaired assessees who might otherwise perform at or near the floor of existing tests. Now, the fifth one, or the last one, is Cognitive Behavioral Drivers Inventory, which was specifically designed to assist in determining whether individuals with brain damage are capable of driving a motor vehicle. And that's all for my report. Thank you for listening. Have a great day.